Okay, we're going to get started on our panel right now, whether you stand up or not. And so the name of this panel is about operationalizing a value-based enterprise. We're talking about value-based enterprises and what they do and what they can do. Now this panel is going to be, how do you actually put one together? And we have three outstanding panelists to help us in that endeavor, who are Marc Miller, right here, who is the President and CEO of Health Strategies, LLC. We have Juliette Price, who you already know because she was our keynote speaker. And finally, we have Marc Auerbach, who is the Chief Legal Officer and General Counsel for Genuine Health Group. So I'm going to ask each one of our panelists to say a little bit about themselves and what they do. And so before we get started, Marc?
Sure, glad to help. Marc Miller. I'm probably on this panel because I spent 20 years in the C-suite of health systems, multi-billion-dollar health systems. I've worked for Advent Health, Vanderbilt Health, thank you, and Ardent Health, all multi-billion-dollar companies in the C-suite. I'm the guy who spent 20 years running the employed physician groups. Some of these organizations, as you know, have thousands of physicians, and fell in love with population health value-based as CMMI came out with MSSP 2012. And I've stood up in six different states: New Mexico, Oklahoma, Texas, Tennessee, Alabama, Florida. I've stood up 6 ACO-CINs, and now currently working with Nelson Mullins in Ed White in setting up a VBE. So excited to be here, happy to be here and contribute.
Hi, everybody, again. I'm Juliette Price from Helgerson Solutions Group, and I think in the context of this panel, we do a lot of work with provider clients, mostly on building ACOs, building risk-taking entities, ACOs, IPAs, sort of however the state you are in wants you to call it. Just making sure we obviously adhere to state and federal laws. And one of the things that our firm provides is helping organizations, whether they're legacy clients, which is sort of what I call providers who have been in the fee-for-service space for some time and may not understand what they need to do to operationalize VBC, or what I call our built-for-value clients who actually emerged with a business plan specifically to succeed in value-based payment, and oftentimes they face different challenges. But no matter what kind of provider group or seeking to be a provider group, the operationalizing of VBE is typically a tough transition. So we do a lot of this work.
Hi, Marc Auerbach. I'm with Genuine Health Group. My background is a lot like Mike's and some of the other speakers before. I was still am a corporate healthcare lawyer. I've been doing it since the mid-'80s, primarily in large law firms, K&L Gates and then Cozen O'Connor, and then had an opportunity to join Genuine Health Group as it was in its formative stages. And I like the idea of being able to both deal with the legal issues, but also some of the business issues and how the two of those work together to put together a company and to grow a company. And that's the opportunity that I have now. And I guess I'm on this panel to talk a little bit about how we actually implemented some of the legal advice, some of the business advice, and how it actually got from paper to practice.
Thank you very much. As I was standing here, I decided to slightly change the structure of how I'm going to do this. I'm winging it. And, you know, by the way, Marc and I go way back. We've been on opposite sides of many deals when he was a lawyer in the regular business before he went in the public. And so we have a long history.
Yes, we do. A good history.
But fortunately, we always got along, except when we were screaming at each other but that was always for our clients, not for us. Okay, but I want to start with you, Marc, because we talk about operationalizing, the first question is what are we going to do? What kind of organization are we talking about? How are we actually going to put this together? Of course, we don't know exactly who the players are in our group, but give an idea how you would think about how you would actually put one of these together from a structural perspective.
Sure, and I think the first, threshold question is, and it's important, what is it you want to be? What are you trying to achieve? And then you can, once you have some general idea, other than just making money, or if you're a not-for-profit, whatever the purposes of that particular not-for-profit are. So I think you have to have a vision of what's the right way to get to where you want to go. And I think there's, depending on what kind of structures you want to develop, I think it leads you on different pathways. So just by way of example, we originally started in our primary was in the Medicare Advantage space, and so we're primarily managing the various providers. So one of the things we thought about was, do we want to be a staff model where we actually go out and acquire practices, which is a slower process, maybe a more expensive process, but much easier to get people to adapt what you want them to adapt? Or do we want it to be an IPA model, which may give us more flexibility and give us a greater chance to accelerate faster, but there'll be subsequent control issues. And so one of the things you have to go through is which of those models work for us. Similarly, what's our talent pool? Who are the people trying to put this together? What's their core capabilities? What's their weaknesses, so that we can kind of think through what type of organization we want to look like. So to me, the first step is, it's almost, you got to start at the end to get to the beginning, which is, if we do everything right and we get to the end, this is what we want to be. So what do we need to think about now to kind of put the foundations to getting to that point in the future? With the one caveat that nothing ever stays the same. So the best laid plans, if they work 80%, you're doing really, really good, because not everything's going to work. The laws may change, the political environment may change, the economy may change, there may be lots of changes. So you do your best to plan, but people ask me, what do you need to be successful in this industry, in the healthcare industry in general? And I'm a big believer in adaptability. Don't get so rigid in what you develop that you say, oh no, it's on a piece of paper that's on row 4 years ago. I don't even know who wrote that piece of paper, but we're sticking to that piece of paper. That's a recipe for disaster.
Juliette, Marc, you guys want to add to this?
No, I think that's a great place to start. I think we talk about beginning with the end in mind, right? And that's exactly what Marc's talking about. And I think the other thing I would just call out is, you need to make a plan for the potential shared savings before the shared savings are here. And this is one of the biggest things that we see that fail ACOs, IPAs, risk-bearing entities, we're just going to call them that, is that maybe they went into it naively, or maybe they just, didn't think there'd be shared savings, and then all of a sudden the check comes. And then, and I think to Dr. Jeff's point earlier, right, then you've got a whole lot of infighting, right? Because the specialist thinks that they generated all those product, right? Then you have the primary care that said, well, wait a minute, we generated all those. That is not the time to decide how you're going to split the savings. It's all up front before any dollar actually comes into the entity, because that is the quickest way to send an at-risk group into flames. And so this idea of beginning with the end state in mind is super, super smart. There are some cases where sometimes you don't have the time to do that. So I'm mostly joking about our CMS colleagues who love to drop, an application 6 weeks before it's due. So sometimes you're pushed to just do something, get into a program, and then sort of design. But you can back up all of these decision points, and you absolutely should.
Well, let me just tell you that from my personal experience, you're 100% right. And the trouble is, even when you're trying to do this before you achieve shared savings, determining the right formula that makes everybody happy is really, it's like squaring the circle. And so you do the best you can, but you have to remember Abraham Lincoln said it a long time ago, you can't please all the people all the time. So you do the best that you can do. Marc, I want to ask you, talking about now that we're creating this thing, how do you work on creating the proper leadership and governance structure to make this thing actually work?
Okay, would you mind putting up the building blocks slide?
Sure. If I can find it, I'll give it to you, no question about it.
Easy for the audience.
Should be towards the end. Hold on.
Yeah, so while he's doing that, I've been in the seat of the CEO, there it is. I've been in the seat of the CEO of the ACO, Accountable Care Organization, Clinical Integrated Network, so my perspective is actually having done it, gone all around the bases, gotten the reimbursement in collaboration with all the stakeholders, being the post-acute, acute care, ambulatory, obviously the patient, the health plans, and the payers, large self-insured employer payers, as well as MA and Medicare standards. So every time that I've stood up one of these and been successful, here are the 10 building blocks. Here we're showing 11, but we were talking a little bit earlier, these are not in sequence, okay? So you don't have to do care management and delivery before clinical performance. The payer contracting strategy is one of the most important in terms of, before you even start with the leadership and governance, as you can see there on the top, we're talking about investment funding. Who is it that's going to be the owner of this organization? Not necessarily the leadership, but the owner of the organization. That is key from the very front. But in terms of number 2, leadership and governance, one of the failures that I've seen more than not, my other panelists probably seen the same thing. Hey, let's take a C-suite CFO or a C-suite health system guy, maybe it's the guy like me who is running the large self-insured and the large employed physicians of this multi-billion-dollar health system. Let's assign this guy or this gal to head up this ACO CIN and see if they can be successful in the value-based space. That is a failure for a strategy. You need someone like you, someone like us, in order to lead this entity who has vast experience in this area. It's moving quickly now, and we've been in this space over a dozen years, many of us who I've been talking to. That's the kind of person that you want to lead the organization. So number 1 is, as a challenge, don't have a traditional health system or a physician group head up the organization. Other thoughts on is sequence of when you don't want necessarily the health system physicians who are employed by the physicians who are employed by the health systems, you don't necessarily want them to overwhelm the board of directors, and you don't want them to necessarily chair each of the different committees. So when you have trustees and or board members of this entity that, and we're working with Ed White, with Nelson Mullins in setting another one of these up, this will be number 7. But what you don't want is to overwhelm the board with physicians who are aligned with and loyal to the health system, because what we want to do is we want the community physicians, in addition to the employed physicians, across all 43 subspecialties within this targeted area to go after helping targeted populations. But you've got to involve, to be most successful, we've always involved the community physicians. So I would implore you, when talking about leadership and governance, don't have the majority of the physicians on the board, which is a good idea, be employed physicians by the health system who happens to also be the owner. That is something that's going to be a challenge for you. And then drilling down to the committees, and I'll stop, whether it's the quality committee, the operations committee, the finance committee, the physician membership committee, you don't want the employed physicians of the health system, if the health system owns this ACO, CIN, and now VBE, you don't want them running the committees as a chairman either. And it's important that the community physicians have a voice at the table. It'd be very difficult to sign them up as members of the organization or their practices if they know that the organization right from the start is overwhelmed by the health system and the employed physician groups. So I'll just stop there.
Well, so I assume that it's important that everybody have some skin in the game.
It is, and I will parking lot, my last thought, because I think that's something that all three panelists can talk to, is it's really a lot of fun trying to figure out the employed physician incentive programs. How do they differ? I'm sorry, the incentive programs from the ACO, CIN, and VBE for the employed physicians of the health system, how does that differ from the incentive programs that you offer to the community physicians? It's a very different dynamic. I can't tell you how many times I've seen the CFO of the health system receive all the money from this value-based enterprise, and somehow, some way it gets filtered before the money actually reaches the employed physicians who are the members of the ACO and CIN. We can talk about that a little bit later. I'm interested in the other panelists' thoughts as well.
Do you suggest that for people who attend these meetings and all these leadership meetings and give up their time, that they get compensated for it in any way?
It depends, and that's a non-answer. Are you talking about a physician when you're talking about coming to these, or being a part of the?
Well, let me just say this. Most medical groups that I have formed over the years, we have paid them not $500 an hour or anything, but they get paid for attending meetings.
Yeah, I've seen it both ways.
Because everybody else is at home doing whatever, and they're at these meetings, and they're entitled to something at least something for the purpose that they're doing it.
Yes, and I know BFMG is here. We're talking about, yes, fair market value, hourly compensation, and employment. Yes, you can and should. I am a proponent of paying for committee meeting time.
Okay. Got anything to add on this one?
Sure. I think it depends kind of what type of organization you have. For instance, if you're talking about an ACO reach, somewhat your board is dictated to you as to who could be on that board and how your board is made up. So you don't have all the abilities that a traditional for-profit entity could go out and just pick and choose who they think is best. And there's a couple of positions there that are hard to fill, and at least I think most part you end up needing to compensate them. The Medicare beneficiary role, the community advocate role, those are board positions that you're probably going to need to incentivize someone to join, because they're not sharing, if it's a for-profit entity, in the bottom line in any way, shape, or form, and they're not getting any other compensation there. The board, paying just to be a board member, I think it kind of depends on how you set up the board. I think, at least in my personal experience, we're trying to focus on board members who bring unique talents and can deal with a specified area. We're not really looking to encourage the person who just wants to get paid and a couple free meals to show up on the board and not to participate at all. So the pay, I think, is secondary. I think it's really more the skill set and frankly, the ability to work in a group setting and to make compromises and to have people who could reach compromises that's good for the entity as a whole rather than a certain subsegment of that entity.
Thank you very much. Well, now that we have this group up and running and we got a leadership situation, we know how we're going to handle the leadership and the governance, now we got to go do what we really are in business for, which is to get some payer contracts. So Juliette, I know you're an expert at that, so can you talk about that a little bit?
Sure. I think the biggest challenge I always have with providers, they simply don't know who their payer mix is. And I run into this kind of all the time, and it still shocks me a little bit. But again, I think we just have to understand their behavior in the context of fee-for-service. They're sending out bills. It doesn't interest them necessarily to understand their payer mix because there's sort of nothing they can do about it and nothing that would benefit them. So the number one thing we always work with our providers on is pulling that payer mix, right? Because too often what I see is, well, I know someone at Blue Cross Blue Shield of, the Tower Club, Fort Lauderdale, right? So I'm gonna go there first, and fast forward 14 months of really painful contract negotiation, and you realize you got 14 patients with that payer, right? And so I see this a lot. I see a lot of providers wasting time in this manner, and so it's often a little bit of, let's start with the end in mind, like go the other direction. Really understand your current patient payer mix and start looking at going where you get the most bang for your buck. Now, there are instances in which your largest payer, for whatever reason, is not the first choice, whether it's a strained relationship or they simply don't want or will not negotiate in value-based arrangements. There's obviously that stuff that comes up, but the number one thing to do is just understand who your payers are. I think the second thing to understand, again, and someone's gonna really hammer me for this, but again, offering grace to the payers, right? Understanding that the person who you usually engage with on the payer side might not be the right person to have this conversation with. And I see a lot of that happening where, oh, I've always talked to the VP of network development, like that's my person. That person probably isn't the VBP lead. And so it can be tricky because you have an existing relationship, but I can almost guarantee you, you're gonna burn a lot of time and energy, and that person's actually not a decision maker. So very quickly understanding who at those plans are decision makers with regards to VBP, and getting in front of those people. The last thing I think is really important to understand, again, giving grace to the plans, is what is their approach to value-based contracting? I think too often we assume it's sort of a one-size-fits-all model, or they're gonna take whatever good idea we bring to them. A really good place to start is just to sit down with that plan once you figured out who and the right person, and just ask them, like, what are their models? What are they trying to bring into the ecosystem? At this point in time, most payers will have preferences. Now, maybe depending on what type of provider you are, you may or may not fit into that model. But coming in guns blazing is not very effective if they already have, and I'll just make up an example, they already have a maternity bundle that they are looking to implement in the field. Instead of, spending 24 months developing your own and showing up, you start there and say, okay, well, this is interesting. I can meet you halfway here. Most of this looks good, but we would request a couple changes. You'd be surprised by how flexible they are, because they are also, especially in the state and federal context, the gun is also to their head. As someone mentioned earlier, CMS has these goals for 2030. So just kind of come in with a lot of good questions. Obviously, do your research. Lots of people can help with that. There's a lot available online, but kind of come in, I would say, like slightly humble, right? Like understand what are their goals? What are they trying to achieve? You'll go a lot further than just kind of coming in with a fully baked plan and demanding a contract.
Well, I agree that just going in and demanding a contract is probably a good way not to get one. But on the other hand, don't you think that you should, if you spent, by the time you go to do the negotiate for payer contract, you spend a good amount of time putting your group together, coming up with all sorts of how you're going to do it, and leadership and goals and everything else. And do you think that you should, even though you got to be extremely flexible, you have a general idea of how you'd like to do this, and basically you may ask them, what's your experience, how are you doing this, and you have to show them that what you put together isn't a joke, that you've got meat on the bones that can be really serious so that they'll take you seriously.
Absolutely. Developing what we call a value proposition is extremely important, and you should not get into a conversation with a payer without a value proposition to offer. I see providers make this mistake a lot. They kind of think like, well, we're going to get in front of the payer, we're going to tell them how great we are, that's really going to motivate them. It's like, that's every conversation a payer has ever had. It is so much more effective to like skip that, skip the fluff, and just go right in and say, hey, look, we're your largest PCP provider in this area of the state. We know how many of your patients we see. That's a crazy important piece of information. Really make your pitches data-driven is hugely, hugely valuable. You may not understand spend because you may not have that claims file, but you can understand in a specific market how much do you represent. The last thing that I'll say is and this may be going too far ahead of the negotiation process, but I've also really talked to providers about being selective in contracting. And I wouldn't call it a scorched earth approach, but if you are a large provider to a plan, make that known. You're not obligated to be in their network. And so, make sure you understand the power dynamic between the plan and the provider. There's no reason you couldn't get out of that network contract. Obviously, plans have network requirements, and so sometimes that can really agitate a plan to say, okay, these guys are serious. They understand the marketplace. They understand if you're talking about Medicaid, if this provider leaves, I'm gonna have to withdraw my plan from this area, right? So just really understanding that marketplace, understanding your role in it, coming with a data-driven value proposition, those are things that are bound to accelerate the conversation. Don't look at a conversation with a payer as a coffee and a catch-up. That's not what this is. It's a business meeting.
Marc, you look like you have something to say.
Actually, I agree with everything that was said with one or two little caveats. I think it's also, we talked about a little bit earlier what you want it to be. And so I think a little bit of that will, depending on what you want to be, it may impact how you go about the contracting. So the entity that I'm involved with, we're more of an intermediary. So we're in between the payer and the provider. So we're not waiting necessarily to have all our providers lined up to go to the plans. So it kind of depends. We believe from a philosophical standpoint, I'm not saying this works for everyone, we want it to be a one-stop shop for physicians. We want to be able to go into a physician practice and say, it doesn't matter what plans you have contracts with or where your beneficiaries are. We deal with all of them. We can manage you across the plans, and you'll get symmetry in your reports, symmetry in your data, going back to the data, so there'll be more synergy applied with it. And then to the point you were making, I think it depends if you have a push or a pull strategy. So if I'm sitting there with groups that have lots of members, I'm going to push the plan because they want the membership. On the other hand, there may be a pull approach where, a plan's coming in, a smaller plan especially, coming into the neighborhood and said, hey, we'd like to be involved with your network. We're willing to assign you a certain amount of beneficiaries, which would be more of a pull strategy. So although it's contracting is a whole separate discussion that's beyond what we're going to be able to do here, but there's a lot of nuances to it, and I think it's important, going back to what we said in the very beginning, what is it you want to be and where do you want to get, and let that help you, let that factor into how you go about getting the contracting.
Marc Miller, anything you want to add to this?
Yeah, an earlier presentation, the keynote that Juliette was making, I thought it was interesting that in terms of strategy, why it is that the large self-insured employer is oftentimes the last payer. They become the risk entity, therefore they are the payer, to have a contract or an arrangement with this ACO, CIN, or VBE. I think you mentioned, Juliette, 53% of these beneficiaries oftentimes in a market, are commercial. Well, the largest of the commercial is oftentimes the large self-insured employer. So every time I've set up one of these and I've developed my payer strategy, if you think about the risk continuum, Ed was talking about the stage one, level 2, level 3, level 2 being care coordination, and level 3 being the partial and full risk. When you do a deal with the largest of the 10 largest in an average metropolitan statistical area, MSA, if you have a targeted population you want to go after, oftentimes the large self-insured employers, the top 10, have 2,000, 3, 4, 5, 10, 15,000 employees and beneficiaries, and yet this is the area that's most neglected in terms of a strategy. So we've always gone in and targeted the large self-insured employers in addition to the MA and the standard Medicare, because on the risk continuum, it's way down there. And if a health system is an owner of an ACO, CIN, or VBE, and they also happen to be doubling as the payer in this case, what a wonderful opportunity to use their providers, their employed providers, their nurses, oftentimes 1,000, 1,500 nurses, and putting together this organization to help them with their own bending down the cost curve of their own health plan as one of the largest self-insured employers in town. So I've been trying to sort of preach, why don't we get more, Juliette, into that commercial? What is the hesitation on the employers and the health systems to get into this space with the large self-insured employers as the payer?
Okay. Well, Marc, we put this thing together, but we have to have a way to make it work. Talk a little about the use of IP and technology in this space.
Okay. I'm going to talk more about the technology than the IP. IP is a separate, complicated area. I'll touch on it. But I think in terms of your technology, it's critical, certainly to evolve and to grow. And there's lots of different areas of where technology comes into place. From the base level, if you're going to be out there, working with various physician groups, is there any uniformity in the electronic medical records? How could you go to, again, with the goal of having, some symmetry in your data, how do you go across different medical record things? What do you do with physicians who have paper-based records? What do you do? So I think technology in maintaining, what often is your baseline data, what's going on with the various patients, that's an important area. I think you also need to think about technology as a companion to the technical, to the staff that you have, and we have to make decisions. Is it better for us as an entity at the stage of development we're currently in to try and build a department, or is it better to try and utilize technology to run that department? And that can come across, and there's hybrids of that. So one of the things, like most of the value-based enterprises out there, everyone's out there trying to monitor and maintain costs. So do you want to have, and we have an at-home program. Do you want to use the at-home program directly, where we staff it up ourselves and send people out to various patients' homes, or do you want to do some hybrid where we send people out, but we also use technology at those homes and leave the technology there that could do some forms of remote monitoring? Or do you just go, and I think especially when there was some talk about specialists, I think one of the trends that at least we're seeing is with some of these specialty areas, there's the rise of new entities, often telemedicine or other forms of digital that are willing to go out there and deal with a subspecialty, a very narrow subspecialty, but no longer are they only looking to do it on a fee-for-service basis. They're willing to do it on a risk basis with some form of subcapitation. So it could be, it makes sense to kind of walk through what your technology infrastructure looks like. Do you want to build more of it yourself, or do you want to use a third party? And there's lots and lots of sophisticated technologies out there that can be very beneficial. I know there was discussion earlier about, how do you deal with the specialists, and the specialists always want to do the right thing and are always going to, do the maximum for their patients. Well, one of the things we use is we engage a company, and what they looked at was who were the primary care, what specialists and what narrow, especially the primary cares, were referring their patients to, and what was the difference in outcomes, both on a cost and on a quality basis, to those specialists in that geographic market. And that's a way, if you gather that data, provide that data to your primary care physicians with hopefully an increase in quality, but certainly maintaining the same level of quality, it may make a huge difference in your cost position based on who you refer to. And you can look at things like discharge recidivism. How many times are the patients being discharged? How many times are they being admitted? What's the cost of the care? And that's just one example. There's lots of different ones, but where you could use some form of technology to achieve your goals. The intellectual property piece of that is kind of the flip side of that. And a lot of it sometimes gets into, entity value. And you want to build your own technology so that it gives you a differential in the marketplace, so that I have a system, this is what my system does, no one else could use this system because we've developed this system to do X, Y, and Z. Now, to do that, you're going to have to go out and hire programmers. You're going to have to deal with legal issues associated with programmers, work for hire agreements, intellectual property rights. So there's a decision tree there. Obviously, from an enterprise value standpoint, if you have your intellectual property that you own and it's working, that's going to be, in the long run, a big benefit. The question is, can you get there, and can you get there in a way that makes sense from your own cash flow standpoint and from what your capitalization standpoint is? Because some of the technology is expensive to build, and it may be, even if it isn't that expensive to build, it may be more expensive to protect. And you get into issues of people want to use, I guess, skip it over a little bit, but on the IP side, it impacts your data too. And when you're dealing with data vendors, they want the right, not necessarily to take your confidential information or trade secrets, but they may want to use some of your product as derivatives, and you want to let them own the derivatives, or do you get the right to use the derivatives? And so there's a very complex world out there that's probably separate and apart from this discussion, but all things that are very important to think about, especially based on your capital needs and what your capitalization is, and where do you want to spend the money? Where do you want to spend your money? But I think it's going to be very hard to be successful in these value-based entities unless your technology is top of the line. And frankly, your technology needs to always be evolving as well. It's a very difficult space, and I think people mentioned it all across. It's a very difficult space to operate in effectively and profitably if you really don't know what you're doing, because you don't have the data behind your decision-making process.
As Juliette said, data.
I agree.
Yeah,
I'm gonna steal it.
I think it's an excellent point, and I think in the ways that we try and own supply chain management, supply chain integration, integration, this is you should absolutely own your own information architecture. To outsource that to other parties is frankly dangerous, because if you don't know what's coming in, how your patients are doing, obviously depending on what kind of group you are, you're the one that's at risk. And so to just sort of say, I'll hire a couple smart people, you should have that infrastructure. You should understand your information infrastructure, and you should own that supply chain, hands down. The thing I tell clients sometimes is you're probably not Mark Zuckerberg, right? You're probably not going to invent something that no one else has ever thought of, right? Maybe you are, but you're probably not, right? And especially for groups getting into this early on, and I know exactly the tool you were referring to, right? There are great tools in the ecosystem today. They are frankly quite affordable. It doesn't break the bank. Get started there, right? Get started with what's on the market today. If in 5 years you need some sort of complex analysis that's not happening, okay, then maybe reconsider. But you're probably not Mark Zuckerberg. Focus on getting good at what you need to do. Let the marketplace tools that exist, go there. And I appreciated Dr. Jeff's example earlier, right? Is where is the innovation, right? Where should we be looking for that innovation? So much has already occurred. I think it's worth thinking through, are you really the best person to push that market forward, or are off the shelf tools really sufficient, which is probably available. I want to echo something else that Dr. Jeff said. Artificial intelligence is here. I know there's a little bit of ew, it just happened, right? ChatGPT, ChatGPT is so old news for people who have been in the computer science, AI, large language model world. AI is here, and we can talk about the clinical side at a different conference that Nelson Mullins will put together. But just for a second on the IT management, knowledge management side, there are incredible tools, again, already on the market today that do incredibly valuable things. And I'll just pick on Dr. Jeff's example once more. Surgeon, physician, care practitioners' notes are just chock full of super valuable information about what happened, what they're observing, even when it's not a specialist, right? There are all kinds of folks writing stuff. All of that is unusable information today, unless you have infinite number of staff hours, which we do not have. And this is an application where AI has proven its worth. And so I highly advise people, again, the clinical conversation about clinical decision-making by AI is something totally different. But there are really great large language model programs out there today that can make a lot of this infrastructure, information infrastructure work less burdensome on you and your team. And I highly suggest that you familiarize yourself with those tools.
Thank you. I'm not nearly as smart as Mark Zuckerberg, but when I was a teenager, I did think about luggage with wheels, but I never did anything about it. Mark, you got anything else you want to add to this?
Sure, I'll be quick. As I've set up these value-based enterprises, I've had some failures and I've had some successes. In those cases where I have partnered with a population health specific, value-based health information exchange data warehouse organization who has spent a decade developing this for this purpose, because there's no such thing as pay for performance. There's pay for proven performance, but you can perform and not prove it. If you don't have the right IT package, you can't prove it. For a decade, these companies, and LACE, for instance, has had the ability to develop what you need in order to show the payers that you have performed, and then when you prove performance, that's when you get paid. So the failure that I've had in the past is whenever my health system is going from Meditech to Epic or Cerner to Epic, they say, hey, why don't we take this EHR from the hospital? They say that they can build this population health thing. I've tried that before. Now, Epic does have Healthy Planet, which is a very nice standalone population health HIE data warehouse. It works nicely, but I've had my most success when I haven't taken an EHR from the health system and then bolted on something they developed, or gone to any one of my practices, any one of the 60 practice management programs, and had them convince you that they can be Mark Zuckerberg and they can develop something off of Athena Health or whatever practice management system that they're using. So that's where I've had success. Go ahead and invest. It's $1.20. It's $1.25, $1.50 per member per month. Come on, guys. You can spend a couple $100,000 to be able to truly prove your performance to the payers and get paid.
Okay. We got about 10 minutes to go, so before I ask any more questions of the panel, anybody have any questions that they have of the panel? We're willing to take them. Don't be shy. Okay, we're shy. So let me talk a little about, we're doing all this thing together, and we're going crazy here, but we've been hearing about the compliance laws and everything, and we're going to hear more about it. What do you do, Marc Auerbach, to focus on how you maintain compliance and have good compliance officers to monitor this?
I think it's a hard position to fill. I think one of the trends you're going to see just generally as we move into more value-based entities is the role of the compliance officer is going to become a more important and complex problem. I know some of these value-based ecosystems now, in the old days, your lawyer would be your compliance officer, but as these ecosystems are getting more sophisticated, it's dawned on them, and I think it's the right decision, that your compliance officer should not be your legal officer, that they should be separate positions because there's different systems. And I'm talking about not just healthcare compliance, but just compliance in general. There's lots of compliance issues related to employment law and classifications, and there's compliance across a large spectrum. the way we've set it up, and I think is the right way to say it, we have a separate compliance department. We have a chief compliance officer. The chief compliance officer reports directly to the board. It doesn't come through the legal department. It goes right to the board. And the board is, we have obviously robust compliance policies, and it's great to have these compliance policies, but any compliance officer will tell you, you have to get those policies out to the people that are governed by the policy so that they understand that they're out there, that they're not, that they're not set up to get back at people for reporting things. They're set up to find things before they become a problem so that they can get addressed early. Because almost all problems, if you find out about them early enough and you address them, can be resolved. It's when they get buried down and then, 3 years later, you're trying to sell your company and no one mentioned that, you've been doing something illegal for, 3 years and now it's a real problem. And probably at that point, I'm not sure it's even a fixable problem, but I guess money fixes everything. But somebody's not going to be happy that wasn't brought forward. So I think you're going to see a more sophisticated level of compliance officers. I think at some point, the compliance officer is also going to morph into a little bit some of the health equity issues as well, and they'll be responsible for how you're trying to achieve, some of the health equity and other initiatives as well. So I see that as an expanding role in pretty much across the board value-based entities.
Anybody want to add to that?
No, you go.
I wouldn't add to that. It's fun being the non-lawyer at a lawyer conference. I would just say that the vast majority of people who work in these VBEs, they're not lawyers, and so there is this level of nervousness, and I think a big thing is just training, and it sounds obvious, but it's so poorly done most of the time, and people really don't understand why they need to be on the lookout for certain things. And I just think we've seen really great examples of companies and organizations get tripped up in it. So I just think, really understanding how to get the bulk of your providers, and I mean that in every literal sense of the word, the person at the front desk, is a provider, right? And how do we get to all levels of an organization to have them understand why it's so important and how to be good stewards of it?
Yeah, so quickly, one of the 11 building blocks that we had up there, you don't have to go there, but it said provider network. It doesn't mean just physicians. It also means the acute care hospital provider. That acute care hospital provider oftentimes has a compliance plan, a compliance program, a compliance officer, and a privacy officer. We've had success in developing a compliance department within the health system's compliance department, and that's worked well. It's just a heavy lift to do a standalone. If you're affiliated with and or owned by the health system, why not leverage their compliance department, do the things you need to do within that compliance and regulatory environment that are different from a VBE than a health system. But it was really helpful for us to bolt on to the compliance department of the health system.
By the way, before we leave, one thing I'd like to say is when you're putting together a value-based enterprise, you have to consider the marketplace that you're in. That when you've seen one marketplace, Jocelyn tells me I have to get closer to the mic. When you've seen one marketplace, you've seen one marketplace. So for example, in South Florida, it's huge. We have 7+ million people. And a lot of penetration into into capitated markets. On the other hand, if you went up to Columbia, South Carolina, where you are and Ed is, it's not a tiny market, but it's nowhere near the size of South Florida, and they don't have a lot of penetration into capitated markets. It's a totally different world, and you have to design that value-based enterprise entirely differently based upon where you are. Even in Florida, if you leave here, you go to Orlando, which is a pretty good population, but it's a different market. Tampa's a different market. They're all different.
Yeah, I have a client whose chief medical officer is just a lovely human, and he repeats this mantra all the time: is healthcare is local. Healthcare is local, and none of this telehealth, none of this will change that. There are some things that national providers and telehealth providers can, but that is on the fringe. That is on the fringes. Most of what people will experience today and in the future will be localized. And so knowing your market, I couldn't agree more, Mike. It's you gotta absolutely understand it and understand it very well using data.
Are there any other questions? Well, if there's, yes. Do we have a mic? We're gonna run over here and let you use the mic. Can you state your name?
For the record, sure.
Everybody knows who you are. I know who you are.
Christopher Acevedo. My question is related to some of the newer programs like REACH. And I'm wondering, A, from a risk perspective for the ACOs participating in REACH, and B, for the providers who are doing the care, what you're advising related to the acute care hospital and or SNF stay where the resident is attributing diabetes so that they can get a blood sugar, or just throwing chronic kidney disease so they can get drugs through the ordering PEC system, and now having voluntarily aligned diagnosis that really don't contribute to patient care, the overall risk score, included in shared saving risk model payments.
That's all the time we have today. That's a super question. It's a really complex one. One of the things that I would also say.
Put together an extra panel just for that.
Yeah, we'll stay after. One thing that I will say I think is good, and I think the CMMI models, they are not all of the same quality against this, but yes, payment, flexibility, but also yes to flexibility on regulations, right? And so I think one of the best things that ACO also comes with is the opportunity for the BEIs, the beneficiary enhanced incentives. And so for those of you who don't know, there's a whole list of essentially, they're essentially waivers around very specific rules. The SNF 3-day stay is one of them, waiving a copay for a beneficiary. These are kind of simple things, but we know that if it's a $20 copay, that may not feel like a lot to you or I, but it can be a lot to somebody, and so they can sometimes not come in. So I think part of it is using all those flexibilities. I think where you're going is this challenge, and ACO REACH certainly I think is the first. It's one of the first steps around the broader challenge of risk adjustment, risk coding, and the challenge that CMS is trying to deal with, and we do not have policy clarity yet on their considerations on upcoding. Obviously, there was the ruling just the other day with the MA executive, and this is causing, I think, just a lot of consternation, and I think there's not a lot of understanding of how the coding works, how the coding cap works, how it relates back to that standard population that is against the cap. So all of those things are super important to understand if you are in REACH. I think the very quick take I have is that ultimately that's not going to be the thing that makes or breaks a REACH performance. However, and this is, I think, reflected in the rule changes that they issued for 2024, they're obviously continuing to evaluate what they can do against that. And I think that's the stuff that I would kind of keep eyeballs on. But also happy to have a sidebar on that.
Thank you very much. We don't have any more time. The keyword, the first keyword for your CLE credits, please write this down, don't forget it, is value. That's V-A-L-U-E, value. Thank you very much. We're going to have a 20-minute break now. Please come back. We got 2 great sessions going forward after this, so both people who are here and also all of those of you who are on virtual, come back to see the other 2 tremendous sessions. Thank you.
Thank you, Mike.